Okay, we'll go ahead and get started. I'm Mike Beasley. I'm one of the sports medicine docs at Children's Hospital of Philadelphia. We're going to be talking about pediatric spine today with Dr. Sweeney. I'll start by talking about future things again. Next week's or the next talk that we'll have is skin infections in athletes with Dr. Tangen. And just as a reminder, the goals of these sessions for these fellow lecturers. The real goal is just education. We're trying to have this as an adjunct to educational content that you get through fellow zone fellowships. Hopefully, we get some direct access to some great educational experiences with AMSSM members and sometimes some invited guests from outside of AMSSM. And hopefully, this covers topics that are going to be big in not only your clinical practice, but in CAQ prep. Hopefully, these serve a great role. Dr. Sweeney is joining us from Children's Hospital of Colorado. She's a pediatric sports medicine specialist there. She's an associate professor at University of Colorado as well. She did her undergrad and med school at University of Missouri before doing pediatric residency at Phoenix Children's, where I was lucky enough to be her chief resident. She then did her sports medicine fellowship at Nationwide. And today we're talking about pediatric spine. This is a special interest for Dr. Sweeney. She is a former level 10 gymnast at Missouri. And then she says she retired at age 16 due to spondylolisthesis, but she didn't really retire. She just changed her role. She is a stellar judge for NCAA gymnastics. She has a great role with USA Gymnastics and has now taken on being an educator as well. So, Dr. Sweeney, take it away.
All right. Thanks. So, I do have a disclosure of AMSSM. We applied for and got a grant a couple years ago to study spondylolysis, and I'll touch on our study a little bit, but that's not the focus of this talk. And then that's a picture of my spine. So this is a topic near and dear to my heart. And luckily, when I talk about some of the spondies and spondylolisthesis with my patients, I can give them some firsthand experience too. So my objectives today, I'm just going to briefly touch on anatomy of the pediatric lumbar spine. Then we're going to talk about best practices for evaluating patients, so history, exam, and your diagnostic workup. And then put a big chunk of this talk into different causes of low back pain that we see in our pediatric athletic population. All right, so we'll start with anatomy and epidemiology. So if you think back to embryology, you don't typically have that normal kyphosis and cervical and lumbar lordosis that when you have as an adult. So you're not born with that. That comes once you start crawling and then when you start walking. So it's just one thing to think about if you ever take care of really, really little ones. And then we do have 7 cervical vertebrae, 12 thoracic, 5 lumbar, and then our sacral vertebrae. It's important to know the structures, the anterior and posterior elements. A couple important ones to talk about here are our transverse processes off the side, our spinous process in the back, the body of the vertebrae here, and then the vertebral foramen in the middle. A different way to look at the spine here, the lamina and pars interarticularis is an important part of those posterior elements, and we'll talk more about that in a minute. The different layers of the disc here, the nucleus, the annulus, and then the lamellae on the outside. And then also in our pediatric patients, they do have these apophyses or little growth plates right at the edge of the anterior portion here, and that's another important one to talk about as well. Muscles of the spine. So there's a lot of muscles that support our spine, and making sure that we're strong everywhere is really important. Again, our gymnasts will often have a 6-pack, but sometimes their deep muscles of their spine are not as strong or as active as those more superficial muscles. So making sure you know about the multifidus and the quadratus lumborum, and then your psoas as well, are really important muscles that should be strong and rehabbed for a patient who is having back pain. The epidemiology of low back pain in our adolescents, it's actually more common than I think a lot of people think it is. Up to about half of patients in or who are adolescents will have back pain at some point. Lifetime prevalence, it's less common in our younger kids, so we don't see back pain a lot in our younger kids under the age of 7. If you are seeing it, there's sometimes red flags that you need to be aware of. And again, we'll talk about that in a moment. As we reach adolescence and then up to 18, we see more back pain. So up to 80% of our adolescents at 18 have had some kind of back pain at some point, which is the same as an adult population. The important thing is a lot of this is self-limited, just goes away after you did something to your back, it's strained, and now it's better. But about 7% of adolescents with low back pain will seek medical care. Again, most cases are non-specific, self-limited, but about 5 to 10% of adolescents will have chronic back pain. This is a nice review that I wrote with a couple of my colleagues back in Ohio, where I did my fellowship. So if you do want to look more about at articles on low back pain, this is a nice review that goes into more detail. And some of these slides are taken from that. All right, moving into risk factors, history exam, and workup. So when you see kids coming in with back pain, kind of what are you doing? So the first is risk factors. So our really highly special or highly active kids, and then our kids who don't do activities, sit on the couch, watch their iPads all day long. Those are the two different populations where we tend to see a lot of back pain. Those kids who just are somewhat active tend to have less back pain. We often see it more in our females, usually when kids are going through their growth spurt. Similar to adults, having some kind of adverse psychological factors does increase your risk for back pain, and also having previous back injuries can increase your risk of back pain. And then if there's a family history, parents have back pain, parents have had spondylolysis or other scoliosis, things like that, there's an increased risk of back pain as well. So if you have one of these things coming into your clinic, just know that may be more common. When a kid, I have a kid on my schedule says back pain, and that's all I have. There's a lot of just differential that I'm going to start thinking about. But the first thing that you want to know is that not all back pain does have an underlying diagnosis. So, our goal is to rule out all the structural causes, but sometimes we don't find a cause. And so then usually what I'm telling kids and their parents is, hey, structurally, if I've done all my workup and I still can't find something, I can't find anything. This may be more functional. And so it's okay to do activity. Our spine surgeons at our institution often say, like, the spine likes to move. So we want kids to be active and they shouldn't be scared of their back pain. But just remember, not all back pain has a structural cause. There was this 2-year prospective study of about 73 kids who had low back pain. And most of them didn't have a diagnosis. They did CT or MRI to evaluate that. The other thing I'm looking at in my differential is is this more flexion-based back pain or more extension-based back pain? So sometimes it's both, but if you're flexion versus extension, your differential may change a little bit. Also, was there an acute injury, or did this just kind of happen over time and it's been, a month, 2, 3 months of low back pain? In my history, it's similar history that you would take for other sports problems as well. So was this insidious onset or acute, just like I mentioned? Is it getting better, getting worse, staying the same? How long has it been going on? Is it all the time? Are there certain things that are causing it? Where on the back is it? How severe is this pain? Is it influencing your daily life, or is it just when you do certain things in your sport? What are your sports activities, and are you still doing those, or have you had to stop doing anything in your sports because of the pain? We're going to talk about red flags, and then also, is there any family history? I often will ask about autoimmune or rheumatologic conditions, because sometimes back pain will be the presenting factor for a rheumatologic condition. Okay, so those red flags that you don't want to miss. So almost every kid who comes in with back pain gets asked these questions from me, and sometimes they look at me like I'm a little crazy because they don't know why I'm asking this. But do you have any pain that's waking you up at night? And a lot of times they'll say, "Well, I can't get really comfortable at night." That's less concerning to me. But if that pain is waking them up from sleep, that's a red flag. Any bowel or bladder dysfunction, I usually just say any accidents, like not making it to the bathroom in time, any pain radiating down your legs, so radicular symptoms, any saddle paresthesia. Usually I'll just ask them this tingling. If they're kind of not sure, then I usually just say, hey, if you were sitting on a horse, the part of you that's touching the horse, is that ever get numb? That's the best way I've found to explain that to kids. any fevers, weight loss, and any peripheral manifestations. So eye issues, so uveitis, so JIA can often present with uveitis and back pain, psoriasis, so psoriatic arthritis, any rashes or things like that on exam. So you want to be able to look at the back, but also you don't want to, totally undress them, make them feel uncomfortable. So I get them, if I can, into a sports bra, or if guys are comfortable taking off their shirt, I do that. Otherwise, I'll have a gown on so I can at least like open the back of the gown and look. Um, you want to watch them kind of moving throughout, and you don't have to do like, okay, now we're standing, now we're walking. Just make it a flow in your exam, and you'll get better at this as you practice it, but you want to have them move around and see how they're moving around the exam room. And then inspection. So looking at the spine, do they have an asymmetry? Is their shoulder height or pelvis height different? Is there any rash or hair tuft in on their back? And then palpating. So I usually just, they'll point to where their back hurts. I start quite above that and I make sure I go below that area, palpating along the spine, along the paramusculature, paraspinal musculature, also making sure I get my SI joints, iliac crest. So essentially all the structures of the spine. If they're a little bit higher up, I'll make sure I get the scapula as well. All right. I always put this dermatome guy in. I can't remember it all. So, it's always nice to just be able to look it up. And that's, we can always do that. We can't know everything. And I think telling patients, like, hey, I'm going to go look at something, it's okay to do. But then, okay, so range of motion, flexion, extension. I always have them do that. Then I'll have them do lateral bending. I just say, like, reach for your knee or bend sideways, like you're doing the little, I'm a little teapot thing. And then rotating and making sure things are symmetric and also not painful. Typically, I'm seeing low back pain, so that's kind of my exam is more based on that, just so you know. So, strength, looking at their hip flexors, looking at knee extension, and then also big toe extension are all really important. So, I just do that on all of my patients, and you're going to check symmetric as well, both sides, doing their sensation and then their strength in the lower limbs. If you need to do upper extremities, do that too. Do your reflexes. So patellar is L4, Achilles tendon is typically S1. Clonus and Babinski, if you're worried about an upper motor neuron issue, and then also always checking their pulses is important. And then I'm going to go into some special tests. So these are the special tests. I do these first five most of the time. And then I almost never do the modified Chobers, but I just want to make sure it's in here in case you have a question on it or you feel like you need to do it. All right. So the first two tests are the stork and the prone hyperextension. So these are your extension-based tests, looking more at the posterior elements. So the stork test is a picture here on the right. You have them stand on one leg and you kind of help them balance by putting your hand the leg that they're standing on, you put your hand on their hip and then you pull the other shoulder back as they're extending. So it kind of rotates them away from that leg. And if that recreates their pain, that's a positive test. And then you'll do it on both sides. The other one I like to do is the prone hyperextension test. It's really easy to do. They're just laying on the table. You have them push up like a seal. Does that recreate your pain? And then I have two flexion-based tests as well. So straight leg raise, you have them supine. You are going to passively flex their hip starting at 30 up to 70 degrees. And sometimes you go a little further. It doesn't have to be perfect. But what you're looking for is pain radiating into the posterior thigh. This may be worse with dorsiflexion of their foot. Now, if they're just like, it's just a stretch or it's just in my back, I will note that, but that's not technically a positive test. And then the slump test is similar, but you have them sitting. So you can see us here in the bottom. And I usually just tell the athlete, I don't put my hand on their head. I just say, hey, I want you to sit with your chin on your chest and your back rounded, like you have really poor posture looking at your belly button. And then I do passively extend their knee with their foot dorsiflexed. And again, you're looking for pain radiating into that posterior thigh and knee. If it's, again, just back pain or just a stretch, that's not a positive test, but you can note that. This picture cracks me up, so I always put it in my slides. So this is the Faber test. So Faber stands for flexion, abduction, external rotation. So you may do this probably in your hip exam, but I also will do this in my back exam as well. So I will do a Faber, and then if they say that hurts, you want to ask them where. So you can see in the questions here. So do they just have limited range of motion with this? Then you're going to think, hey, is there something structurally in their hip going on, like FAI or some other hip arthritis? If they're like, ooh, it's more just like on the outside of my hip, then, are they just tight there? If it's causing pain on their lower back, then you're going to think SI conditions, so sacroiliac conditions. So you want to make sure you're asking where that's causing that pain. And then finally, the modified Schober. So again, I don't do this very often. If you're worried about a spondyloarthropathy or an autoimmune condition, then you may want to do this. So how this one works is you feel their iliac crest, and then you're going to measure 10 centimeters above this, and you have to have a measuring tape and a pen. Those are two pieces things that you need for this test. You're going to measure 10 centimeters up from their PSIS, and then you're going to make a little mark, and then you're going to measure 5 centimeters below that and make a little mark. So it's 15 centimeters. And then what you have them do is you forward flex, have them forward flex, down, rounding their back as much as they can. And the skin should stretch to 21 centimeters. If it's less than 21 centimeters, then you think, they're either just not very flexible, have really poor flexion, or they may have some kind of spondyloarthropathy. So the test you can do. It's not a perfect test, but if you're worried about it and you want to impress your attending, you could do that one. Okay, so we've done our exam and we want to get x-rays. So I typically will get x-rays on almost everyone who comes in with low back pain. If they've had back pain for like 1 day or 2 days and their exam is pretty reassuring, I'm probably not getting back pain. But if it's been more than 2, 3 weeks, I think it's time for an x-ray. I always get an AP and a standing lateral lumbar spine. The reason for this is if you get a supine lumbar spine, you won't be able to see their lordosis curve well. And if there is some kind of spondylolisthesis or slip, it may reduce when they're supine. So I always encourage people to get standing AP and lateral. I do not recommend obliques. The AAP, the American Academy of Pediatrics, doesn't recommend obliques anymore. That is the one where if you're, again, talking about spondies, you'll see that Scotty dog collar if you're reading about this, but it's not often there. It adds a ton of or a decent amount of radiation to the patient. And if it's a young kid who's skeletally immature, you maybe don't want to add more radiation to them. And it doesn't add a ton of diagnostic value. So we don't typically recommend just the AP and standing lateral is typically what we would recommend. And then advanced imaging. So SPECT has been in the past a common diagnostic tool that we used for spondylolysis or a stress fracture of the spine. It's not used very often anymore, just due to the dose of radiation that it has, and because that MRI over the last couple decades has really the ability of MRI to pick up things has improved significantly. So I think it's important to note SPECT or CT is often considered the gold standard for some issues, but MRI is typically where we're going to go after x-rays if we want to look for more detail. Again, CT is good for bone and cartilage detail, but it does have radiation. And the MRI is nice because in addition to looking for a bone stress injury like spondylolysis, it also can help us look at the discs, the ligaments. Is there some other kind of arthritis going on? So usually if there's a question on boards about what's your next test, I would say it should be MRI. Labs, I don't do a lot, but I think it's important to know like when to get labs or in which labs to get. So if you do think there is something either inflammatory or infectious or some kind of malignancy going on, you're going to want to for sure get your CBC, ESR, and CRP. And then if, again, malignancy is the concern, you probably want to add in an LDH and a uric acid. If you think it's infectious, you probably want to get a blood culture too. And then rheumatologic, if you're worried about that, you can get an ANA, a rheumatoid factor, and then HLA-B27 is often a little bit better for those spondyloarthropathies. These aren't very specific or sensitive. Rheumatology sometimes doesn't like if we get them ahead of time, but they are really helpful if you want to confirm a suspected autoimmune diagnosis. So sometimes I'll get these just because I'm not quite sure and I'm getting the MRI and sending them to rheum anyways. But a lot of times if I'm going to send them to rheumatology, I just let rheumatology start with the labs and then or do the labs there because usually I end up missing one thing that they wanted and then they get poked anyways. And kids don't like getting poked. Okay, I'm going to move into the specific conditions. There are a lot listed here. Some of them, primarily spondylolysis, I'm going to talk a little bit more about than the others, but this is just the list of what we're going to talk about. Okay, so spondylolysis, which I'm going to call it spondy throughout this talk, is the most common structural cause of low back pain that we see in our young adolescents. It's a stress fracture to the pars interarticularis. So remember, I mentioned that was in the posterior elements of the spine. It's this thin area that is just more prone to stress. We think it's in about 20 to 30% of pediatric patients who come in with back pain have spondylolysis. So about a fourth to a third of them. Typically, they're some kind of athlete, though sometimes they may just be like, the only thing I do is PE class and my back hurts when I run or do PE. We often see this in athletes who do a lot of extension and rotation. So, gymnasts are a big one, our divers, dancers, our football athletes who are like coming up off the line and arching, baseball with and volleyball with that rotation. But really, again, it could be any sport. So I think anytime you have an athlete with extension-based low back pain, you're going to have this near the top of your differential. It's most commonly L5, and then the next most common spot is L4, and then occasionally you'll see it at L3 or L2. I've never seen an L1. We call this isthmic spondylolysis. There's various types of spondylolysis. Isthmic spondylolysis is the stress fracture type. So there's the congenital spondies who it's a kid who's never had low back pain and they have a bone stress or they have a spondy on X-ray, but they're like no, and they're maybe very very young. But usually these are our adolescents who have this bone stress injury. There's various ways to classify them. So the first is the early progressive or terminal, and you would classify this based on X-ray or CT. So our early spondies, they on X-ray will probably look pretty normal. They may have this really tiny defect, and then on CT, you'll just start to see a little bit of bony absorption. Once they become progressive, the defect is much wider. And then I didn't finish the sentence on this. The terminal one, this is a defect with sclerotic change and with a lack of chance of healing. So these terminal ones typically do not heal very well. With bone to bone. And we're going to talk about, do they heal bone to bone? Do they need to heal bone to bone in a minute? But that's one way to classify them. The other is just, is this acute or chronic? So your acute spondies, if you get a SPECT or an MRI, they will have edema on them. So usually, again, we're doing an MRI, we'll see edema at the pars. They often will not have a fracture line, or if there is a fracture line, it's just very narrow. Once they become more chronic, that defect is widened. The margins are really well seen, even on X-ray. And then if you get an MRI, you're not going to see edema. So you'll just see that fracture line without the edema. Again, this one's unlikely to heal bone to bone. All right. So on your history, typically they're going to have pain with extension or twisting. The pain typically improves with like bending forward or resting from their sport. And sometimes it goes down into their buttocks or posterior thighs. Again, that's the common history. I will say clinically, I've seen all kinds of weird histories with these, but your board history is pain with extension, usually like a gymnast doing a back walkover or back handspring. On exam, they're often tender right over those lower spinous processes, so like L5, L4, L5. And then when you have them do extension, they'll either like try not to extend very far. So they may say, no, that doesn't really hurt because they're just not doing it, or it will hurt when they extend. And then if you do that stork test, that's usually positive. On here, you can see this is one of those defects right through there. And then here's some edema in the pars that you can see with that defect right there. That's what you're typically going to see on MRI. How do you manage these? So typically you're going to have some form of rest, and then I would say it takes 2 to 6 months to return to sport. There is differing opinions in how to manage these. Some providers brace them, and they may use a hard brace or they may use a soft brace. They may have you allow you to do activity in the brace. And then how long do they wear the brace is varied. I would say I don't brace, and I was just trained at an institution where we don't brace, and most of my kids get better. So I don't brace. There was a meta-analysis of over 600 patients, and most of them will have successful outcomes with or without bracing. And I think, again, in my perspective, is that kids don't really like to wear a brace. Obvious that they're wearing it, but I know, like I think Dr. Beasley probably does some bracing, and so it's either there's no wrong way to do it here. And I often tell my patients that, like, you can go down the street to another sports doctor and probably you'll get a different management strategy. There, it does look like the spondies that are unilateral versus bilateral, and those more early spondies are more likely to heal with bracing than like your chronic spondy that is bilateral. Other things you should think about doing when you see a patient with spondy is screening them for relative energy deficiency or female athlete triad, because this is a bone stress injury. There's some people who use a bone stimulator. Um, I don't, just because they're usually not covered by insurance. And then very rarely do you need surgery for these. I would say if a patient has taken more than 6 months to get back to sport and I repeat their MRI, which I don't typically do, and they're still having pain and their spondy's still there, I will often send them to our spine surgeons, but I've never in 10 years had one of our spine surgeons actually operate on me. Okay, so I mentioned rest and PT. So we know that taking kids out of sport when they have this bone stress injury or just any injury leads to atrophy of spine muscles, can lead to mental health issues like anxiety, depression, weight gain. So there was a study done in Ohio at Nationwide Children's where they started PT right away. So basically, what they had the kids do was as soon as they were diagnosed with a spondy on MRI, they put them in PT versus they just had them rest for a while and then they put them in PT. And it took 2.5 versus 3.5 months. So we did this multi-site study kind of mimicking this preliminary data at Nationwide and then also in Colorado, where we again started kids in PT as soon as they were diagnosed, or we had them rest until they were pain free with ADLs for 2 days, so 2 consecutive days. Then they started PT. So the first group started PT in about a week. The second group started PT on average about a month later, a month after their diagnosis. And they got back to sport about a month difference as well. So 2.5 versus 3 months. So I would say on average, kids are coming back to sport 3 months. Looking at these two groups, there was no increased recurrence of back pain over the following year. And so we feel like it's safe to start PT. And so you don't need to rest kids from full sport and from all activity. We do still have them rest from sport and then the PT progresses them back. So there's a specific progression that they would do to get back. Um, the PT progression, they start with the spine being in a neutral position. So, and then they slowly progress to doing some pain-free motion. So a little bit of flexion, a little bit of extension. Then they start running and jumping. And then they add in that full extension in our end range sport movements, like full rotation at the end of the progression. And it seems to be going well. So our study will be published hopefully very, very soon. And you will be able to read that. All right, more on spondies. So I mentioned bony healing, and so some of these heal bone to bone, but not always. So bony healing does not show improvement in pain, function, quality of life, or their ability to return to sport. So there was a study is a small study, so 39 patients. They had a spondy, and then about 9 years after their diagnosis, so many, many years after their diagnosis, they looked at those patients with another CT scan, and only about a fourth of them had bony healing. The unilateral ones were more likely to heal bone to bone than those bilateral ones, but there were no differences in pain between those who did and didn't have bony healing. So even if we have a patient who, like, I can still see your spondy on X-ray, but you have no back pain and you're returned to your sport and you've done everything and your exam's totally normal, I am not totally worried about that because again, it probably just healed with scar tissue, and as long as you're pain free and feeling good, we know it's safe to keep going. Spondylolisthesis. So this is can happen if you have a bilateral spondylolysis, and then the superior vertebrae starts to slip forward in relation to the one below it. So you can see here, this is an L5 spondy on S1, and it has slipped forward about 20-25%. So we grade these 1 through 5. So a grade 1 is if it's slipped about 0 to 25%. If it slips 50% or up to 50%, that's grade 2. 3/4 of the way, so grade 3. If it's almost off, that's 100%. And then a grade 5 is considered a spondyloptosis. These grade 1 and 2 typically are maybe asymptomatic, or they may just present just like a spondylolysis. They have really low rates of progression. So usually less than 5% will progress to grade 3 or more severe. but it's important to follow them, especially if they're skeletally immature. So I usually see these kids back, once they've gotten back into their sport, I'll get a standing lateral x-ray, make sure that looks good. Then I may see them at 6 months and then yearly until they're, about 16 to 18, just to make sure their slip doesn't progress and that they're still feeling good. That is that's spondylosis. So now we're going to run through some of these other causes uh, of back pain, but not in as much detail. So scoliosis is a lateral curve of the spine that's more than 10 degrees. So you may see a kid who, comes in for potential scoli, or you think they have scoli and you measure 8 degrees, then that is considered spinal asymmetry and not scoliosis. The most common type of scoliosis we see is idiopathic adolescent. It does cause pain in up to about 30% of patients with scoliosis. And so this can be a structural cause of pain, but they may not have pain as well. You may just notice they have a curve. Looking at their Risser score on their x-ray can help determine maturity. So a Risser score is you're going to look at their iliac crest, and it's hard to see in this picture because it's relatively small, but there's a little line right here. So their iliac crest apophysis has started to show up. So this patient's probably a Risser 2, I would say. So Risser 0 is they have no cap on that growth plate yet. And then again, it goes 1, 2, 3, 4. So once it's 4, it's all the way across. And then a Risser 5 is that the growth plate has closed. So sometimes a Risser 0 and 5 can be a little misleading, but hopefully your age can help you with that. So if they're younger, so Risser 0, 1, 2, you're going to say, oh, this patient potentially has a lot of growth still to happen. And so their scoliosis may continue to worsen. And so that can help you decide if you need to just monitor this or send them to a spine surgeon. You diagnose scoliosis with an Adams forward flexion test, which is just bending forward, reaching for your toes. You can use a scoliometer if you want. It's basically a level. But if you notice a visible asymmetry, you're probably going to get a scoli film. You can also look at their hip and shoulder asymmetry because sometimes a leg length discrepancy can mimic scoliosis or make it look like they have scoliosis. So you want to make sure it's not a significant leg length discrepancy. Again, you want to get standing x-rays, especially your AP. You may want to go ahead and get your lateral as well, just to look and see if there's any abnormal appearance of the lateral view. And then you're going to want to look at their curve and as well as their age and skeletal maturity. So when do you want to send this to a pediatric ortho spine surgeon? So if they are younger, on the younger end, so usually they're premenarchal, they're maybe Risser 1 or 2, and they have more than a 20-degree curve, they're potentially going to brace these patients so that their curve does not progress. It's probably not going to make the curve better, but that you don't want it to get worse. If a patient has more than about a 40-degree curve, then you're talking, do they need surgery or not? So those are the patients who I'm sending. Again, most patients who are pretty young, I will just send over because they're going to want to follow them and make sure nothing is changing and potentially brace them. Disc pathology. So this can be called herniation, protrusion, extrusion of the disc. You'll see this a lot more in adult patients, but occasionally we do see this in our pediatric patients. Usually it's our adolescents, teenagers. They often will report an acute injury like I was deadlifting, felt pop, had all this pain. Now it hurts to bend forward, to sit, or to Valsalva, like cough, sneeze, or bear down. They may have really poor hamstring flexibility. They're probably not going to want to bend forward. That straight leg raise and that slump test. Again, you're going to want to see, is this causing pain radiating down your leg, or is this just causing back pain? Their x-rays often will look normal, but you want to look at the disc space. So the space between the vertebrae, does that look a little more narrow in the spot where they're having pain compared to the other spaces? If so, you should be worried about a disc injury. And then typically, if I'm really worried, I'm going to get an MRI, especially if they're having any nerve injury, because you want to see, or sciatic type symptoms, because you want to see if that nerve is being pinched and if we need to do something other than just kind of watchful waiting using NSAIDs and PT. So that is what we typically do, is doing some rest, avoiding those painful activities, a McKenzie extension-based program. So that's getting that patient out of those painful movements to start. So they start more in a neutral and extended spine and then move more into flexion as they feel better. Occasionally, you can consider using oral steroids. There's questionable efficacy of if this works or not. I sometimes will offer this to patients just at like a soluble dose pack. Sometimes makes them feel better. This can be, the studies show it's a little more helpful in the more acute phase. So if it's been, 6, 7 weeks since their injury, it's going to be less helpful than if they came in that first week. Steroid injections, same thing. Usually I'm trying PT first, and only if they're failing PT and just really uncomfortable and not able to get back to their activity do I talk about sending them to a spine specialist for a steroid injection or for surgery. Um, at least half of patients have good success with conservative treatment of a herniated nucleus pulposus part of the disc. I would say our anecdotal data is better than that, but it's something to always consider if you're having failure of treatment with PT and rest. Apophyseal ring fracture is not super common, but this is a growth plate fracture. So remember, I mentioned that the apophyses of the growth plate are right at the edges of those vertebral bodies. If a patient comes in and they kind of act like a disc, and you end up getting an MRI, or you for some reason get a CT, or you see this on X-ray, then you could say, okay, yep, I think this is a apophyseal ring fracture. If the fracture is in the posterior portion versus the anterior, then you're going to be a little bit more concerned that this may affect the nerves and the spinal cord. And so you may be a little more aggressive in sending them to a spine specialist. But otherwise, if they aren't having any radiating symptoms and you're not worried about the discs and or the nerves, then you can just treat them like you would treat a disc. Atypical Scheuermann's. So this is something you'll see in patients if they're often complaining more of more mid back pain. So we'll tend to see this more in the thoracic or thoracolumbar junction. Atypical Scheuermann's is it's a collection of symptoms that we'll tend to see. So usually we're seeing these end plate changes called Schmorl's nodes. So I'm going to point one out here. So you see on this like red drawing how the bone looks like it has like that little disc in or divot in there. And so what's happening with that is that the disc has herniated into the bone when it's soft. And in kids, those bones are a little bit softer. So the disc can kind of push down into that bone. So you'll see those are called Schmorl's nodes. You'll also see some disc space narrowing. And then you'll see some vertebral wedging. So you can see here that instead of looking like a nice square, like this vertebrae down here, this one on the anterior portion is a little bit more narrow than in the posterior portions. These patients will often present just like a really flat back. Their thoracolumbar junction, they won't like want to move much there. It's just like they're moving above and below that. There's not a lot we do for this. We can't really like fix the structural changes unless they're super severe. But we can do some activity modifications. So if it hurts, don't do it. Doing NSAIDs can be helpful. Sending them to PT to really work on posture, working on making sure their lumbar spine is stable, their thoracic spine is moving as much as we can, as well as their hips. And then occasionally doing bracing. If their kyphosis is pretty significant, then you are going to want to send that to a spine surgeon as well. But typically, using just PT can be helpful for these patients. All right, facet arthropathy, so inflammation of the facet joints. These will present really similar to spondy. So a lot of times I will just be like, oh, you probably have a spondy. Let's get the MRI. But then we do advanced imaging and we will see that the facet joint is more irritated. So they often have extension-based pain. They may have pain with axial loading. So like when they land or jump, that will cause pain. You can do SPECT or CT, and occasionally you can see this on an MRI, but you'll see irregularities or edema at that facet joint. Treatment is similar to treating a spondy. So you're going to send them to PT, avoid activities, and only if they're failing, then you could consider some image-guided steroid injection as well. All right, next up is Bertolotti's or a transitional vertebrae. So this can just be an anatomic variant that we see, but when it's causing pain, then we would treat it. So this is, you can see on this spine here that the last vertebrae, the last lumbar vertebrae on the right side here looks very normal, but the left side looks quite large and it looks like it is touching our iliac crest in the sacrum. So when we see that, that can often cause low back pain, usually just like presents insidiously. Um, they won't want to extend often with that as well. And then if you got an MRI, you might see some edema there. If you got a SPECT, you would see that they'd have increased uptake. And then on the CT, again, you just see that abnormal anatomy. So again, most of the time you can just diagnose this on X-ray. And if you see it, then you say, yep, that's what's happening here. Doing PT, again, doing NSAIDs and activity modification are typically what we do. And then only if kids are just really having significant pain and failing conservative treatment would we send them to talk about surgery with a spine surgeon. But it's just resection. And so it's not a fun surgery to do. And I would say, again, I haven't ever seen anyone need surgery for this in my clinic. All right, moving on, we're almost to the end. Sacroiliac pain and dysfunction. So this can be a sprain or just degeneration of the joint, usually due to just repeated activities over and over and over. If you hyperextend the spine or you compress really well, really hard, and you don't have good mechanics, that can cause irritation of the SI joint. There'll be pain usually in their like buttocks and posterior thigh. So it's usually just a little bit more inferior to where you would expect like a spondy to cause pain. And then that Faber is going to cause pain there. Sometimes you can compress the pelvis either posterior to anterior or laterally, and that will also recreate their pain. Their x-rays may look normal, but if you get an MRI of their pelvis, you can see a little bit of joint degeneration or edema there. Similar to other conditions, you're going to modify their activity, do PT, maybe do some NSAIDs, and then potentially a steroid injection if they're not improving. All right, hyperlordotic low back pain, mechanical low back pain, also called functional low back pain. So this is a common thing we see once we've ruled out all other structural causes. We often see this in kids who are going through their growth spurt, so our preteen, early teen patients. When you start growing, your thoracolumbar fascia get really tight because they grow a little bit slower than those bones. And so there you can see here in this cute little drawing that the thoracolumbar fascia are tight, and then also their hip flexors will be tight. In in conjunction with that, their deep core muscles and their glute muscles will often be weak. And so they'll have this kind of exaggerated lordosis when they come in. Their exam may look very similar to a spondy. However, all your imaging studies are normal. So normal X-ray, normal MRI. So when I see this, I often are sending them to PT, still letting them do some activity as tolerated, as long as their pain's pretty minimal. And then sometimes these kids, I just give them a brace for comfort, so a soft brace. I tell them it's not really going to fix the problem. PT is going to work on that and also time. But sometimes that brace, especially if they're having a lot of pain just sitting and standing, can be helpful. Inflammatory conditions, not super common, but we want to keep it on our differential. So JIA, spondyloarthropathies can cause chronic back pain. So usually these patients come in with back pain for more than 2 or 3 months. They often will complain of morning stiffness that gets better as they get active. So you want to ask that, like, well, how long is your pain in the morning? Because sometimes patients will be like, yeah, it hurts, but then 2 minutes later after getting out of bed, it's fine. That's less concerning. But if it's an hour or two, and then once they've gotten to school, it feels better, that's more concerning. The pain may alternate, like they may say, oh, it's more on my like left butt cheek and then more on my right, kind of goes back and forth. It may wake them up at night. They may have that positive Schober test. So if you're again getting some of these positives, this may be a time when you want to do that Schober. Your x-rays will often be normal. And so if you're worried, usually if I do want to get advanced imaging, I'll get an MRI with and without contrast to look for that inflammation. And then usually I'm sending them over to our rheumatology colleagues. Tumors and other masses, also not common, but my first year as an attending, I got to see an aneurysmal bone cyst in the sacrum. It looked very similar to this one here. So this can be benign masses or more malignant masses. And so if you have a patient who comes in with back pain and they have any red flags like that weight loss, just not feeling good, night pain, night sweats, saddle anesthesia or weakness, like they can't walk on their toes. That was my patient. Um, then you're going to want to get advanced imaging, an MRI with and without contrast, or a CT, and then also get some labs as well. And usually, if I'm worried and I see any of these significant red flags or something, my spidey senses go up, I am going to get my MRI stat because I want to get it, as quickly as possible. And I may be calling my ortho oncology colleagues or spine colleagues as well. And the infection's also not common, but you want to keep, discitis, osteomyelitis, or an epidural abscess on your differential. So these kids are usually, they're often more younger patients. So if they're just fussy or they're limping or they have fever, they may present with back or abdominal pain. They may not want to sit in a certain way, or they're always wanting to, stand up or lay down and not sit down. That's a red flag. And so you're going to want to get labs and then also that stat MRI with and without contrast. So, in summary, the first is that always get your history and do a really good back exam. Consider getting your two view standing x rays if they've had pain for more than 2 or 3 weeks, or if they have that acute injury or just anything is concerning to you. Many of our older pediatric patients won't have a structural diagnosis, so they may just have more of that functional or mechanical low back pain. Usually, if you're going to get an advanced imaging, it's going to be an MRI because we don't like to radiate our pediatric patients if we can help it. Spondylolysis is one of the most common diagnoses. And then usually our treatment is going to be PT, avoiding activities that hurt, and some NSAIDs. I'm happy to take questions. It's about 45 minutes in, so I'm happy to help you guys out. And these are some references.
Thank you, Emily, for this lecture. This is great. Very the pediatric spine is a tricky one. I think you see it the same way I do. I think it's very, very different. That point at the end that you made about structural versus functional causes, I think the pediatric spine we see is just so different than the adult, right? Like the 16-year-old who has extension-based pain and plays any version of a sport is usually like click button X-ray MRI because we just know that the spondylotic risks are so incredibly high. And a 24-year-old with the exact same pain, I'll go to PT. The numbers are clear that the risk of a structural cause of pain in pediatric patients is so high, and in adult patients so low. So it's we have to be a little bit more trigger happy with our imaging for pediatric patients for sure.
All right. It looks like there's a couple of questions, which is great.
Ooh, you're
Um,
seeing them. I'm not seeing them.
it kind of popped up weird, but I can see them. So, okay, the first is how do you treat chronic back pain in adolescents that are MRI negative and PT and NSAIDs have been ineffective? So that's a great question. I think there's a lot of factors that go into this. One is again, I'm convinced there's structurally nothing. Maybe I'm even going to get a CT just to prove nothing is there. Then I talk to them about like what do they want to do? Do you feel like your pain is manageable and you want to play through and this is just more functional? Sometimes I will also refer them to, we have a complex pain clinic that has a pain physician there, has PT there. And so I talk to them about how like PT can help with different types of exercises and how to manage your pain. Sometimes they'll do various injections. Sometimes they have psych there as well, just to learn coping mechanisms. So that is an option I give them as well. Sometimes I switch up their PT. Also, a lot of times talking to them about like, are you doing your home exercises? Have you taken a break from the activity that was causing the pain? So there's lots of different things. So I think that's how I approach that. So it's not one size fits all for that one. Um, for disc herniations, do you rest them from sports until no pain with extension, or what are your guidelines for return to sport for this? Um, I would say for that one, it depends. So a lot of times I'm using, so I send all of them to physical therapy and I have PT help me. So if PT feels like, hey, you're a cross country runner and your pain is 2 out of 10, and you have a meet coming up, I may let them go back if it's been, a decent amount of time and they've been compliant with their home exercises. If they're wanting to get back to like football and they're in a position that's really uncomfortable for them, then I may not. So my in general, my guidelines for return to sport are minimal pain, which I know is subjective, so it's different for everybody, but minimal pain, full range of motion or really close to full range of motion, and then full strength. So they need to have equal strength in both legs, be able to jump, land, and be able to functionally do whatever is needed for their sport without altering their mechanics. So occasionally I would let them go back to sport if they have a little bit of pain. Um, and yeah, like sorry, and you said discrimination with extension. Yeah, if they have no pain with extension, that's good. A lot of times the discs don't hurt with extension, it's more the flexion. All right. Do you prefer PRP for SI joint injections for peds? Um, so I do no injections in my clinic basically because I am not ultrasound trained. So I have two pediatric colleagues who are uh, uh, trained in ultrasound who do all of our injections. If I have a patient, I our most of our peds people don't do spine injections. I at our institution we send them to interventional radiology, and so interventional radiology typically does steroid injections. They don't usually do PRP. I have not seen them do that, but I don't think that's out of the question. I just don't know if there's good evidence for it. And then what about Tenjet? I don't even know what that is. So I don't know. That's a great question. Dr. Beasley, do you have any answer on that?
Yeah, so Tinjet, needle-based evidence to like take down soft tissues,
Hmm.
and
Is it like
so
10x?
yeah, can you get a procedure for rotator cuff tendonitis and things like that, and
Hmm.
so I would say we don't. Again, I don't do a ton of injections in my practice, especially now that I see predominantly peds. We just don't do it as much. I would agree. If I'm, I think the benefit of steroid is sometimes both the for like a SI joint, is it both diagnostic and possibly therapeutic. Diagnostic and the version of is therapeutic. TINIT I have not seen as much in the spine. We just don't use it in our practice. I'm sure in the adult population. Um, it might be more than that. And then PRP in like the Olympic facilities, they do it, which I'm sure you've seen. And so more than in the pediatric spine.
Right. This one is I know you have not generally observed much curve correction in with bracing, I think in scoliosis. May I ask, have you encountered any scoliosis patient that used the Rigo Chenot brace? I have not. So anyone who's needing bracing for scoliosis doesn't come is out of my clinic. They go to our pediatric spine specialists. So I cannot tell you which braces that they use. Because I don't see those patients typically. Um, the next one, what is a typical patient you'd see that you wouldn't order an MRI and start with an X-ray and PT? For example, if they only had pain with flexion and no red flags, no MRI, would your criteria for MRI be more concerned for spondy malignancy infection, et cetera? Well, that's a good question. So if I have a patient who um, one on an x-ray, I'm pretty confident I'm seeing a spondy and they look and act like a spondy. Like I had one yesterday. That patient did not get an MRI. We talked about it. I said, I could confirm that you have a spondy with an MRI, but I don't think we need it. And they were like, yeah, we don't want it. Um, if they have come in with just a couple weeks of pain, their exam's pretty reassuring. Maybe they have a little bit of pain at endpoints any which way. I may say, hey, we can talk about activity and what we're doing. We can get you into PT first. If I'm like, ooh, this sounds like a spondy, I may say, hey, you can't do sport right now, but you can start PT and then progress back to your sport. A lot of our athletes who come in, young athletes, don't want to rest from their sport. So they're like, no, I want that MRI. Occasionally, though, you'll have kids who are like, I'm not in season right now. I have time, to take a couple of weeks off. Let's start PT and progress back. And then if after, 4 to 6 weeks of good PT, they're not making good progress, then I might get that MRI. So you don't have to get an MRI. But I think if you're really thinking this kid may have spondylolysis or something more concerning, then I think you should get that MRI. But again, there are 10 different ways to do this. You should definitely talk with your team in your attendings. But I would say that's a common, I'd say, pediatric approach is typically getting the MRI. You don't always have to, but you may be resting them for a little bit. I think that's all the questions I can see.
That's all I see as well. Yeah.
Great.
So, fantastic. There are through the AMSSM website, you guys can give feedback on topics you want to hear and feedback about what you thought of these talks and any suggestions. So by all means, feel free to hop on and give feedback. We love doing these and always looking for new topics that people want to hear about. Otherwise, unless Andy, if you got something else, I think we're all set.